Good morning, everyone. I hope you can hear me. If not, please let us know as soon as possible. I would like to welcome you to the International Conference on Children and Their Families using the multiple indicator cluster surveys. My name is Beshanski-Pedersen. I'm a household survey expert with the Global Mix program. And I've been working with the Mix program for, well, upwards of 20 years. One of the responsibilities that I have within the program is to lead on our GIS work, which is one of the reasons that I am chairing this session today. I will be leading the session on geographic and spatial analysis, or at least the first part of it. We have another session on this in the afternoon. I'm joined by a co-chair, Achraf Mrabet, who is a data and analytics manager from the UNICEF office in Pakistan, who has papers at this conference, but is also a long-time friend of the Mix program and has worked with us for many years. So I would like to thank Achraf for joining me. Before I introduce our speakers in this session, a few words of housekeeping. This session will be recorded and hosted on the UNICEF Mix website and YouTube channel, as well as on the BPI YouTube channel and embedded on the BPI website after the event. By attending the event, you consent to be part of the recording. Please ensure that you have added your name rather than being listed as guest, as the team will be monitoring attendees, and we will also need to know who is asking our speakers any questions. You'll be able to ask questions via the Zoom app's Q&A function, which can be found at the bottom of the screen. Because of time constraints, we may not be able to answer every question, but please feel free to get in touch with the speakers after the session to continue the conversation. That is obviously a lot easier if you are present in Bristol, but nevertheless, it should be possible otherwise. We kindly ask you to be respectful, as all events at this conference are being monitored, and we reserve the right to remove attendees whose comments are deemed offensive or derogatory. Please note that the chat function, the usual chat function in Zoom, has been disabled. You have to use the Q&A function. And now with this session, we have 3 sessions this morning, and we will start with the session titled Estimating Safely Managed Drinking Water Services Using Georeferenced Cluster Locations in Lao PDR. This is presented by Esther Greenwood of the Department of Environmental System Science in the Swiss Federal Institute of Technology, EWAC in the Swiss Federal Institute of Aquatic Science and Technology, and the International Institute for Applied System Analysis in Austria. Esther is joined by one of her co-authors, Nazim Gashi, a GIS expert in the Global Mix program. Esther and Nazim, the floor is yours. I kindly ask you to keep it to 20 minutes, and I will be making myself noticeable if you hit towards 20 minutes. Thank you.
So, yeah, it's a pleasure to be here today in person and meet so many colleagues who we've been collaborating with over the past years. So we are today focusing on estimating safe drinking water. And this is the target indicator for SDG 6.1. So we look at safely managed drinking water services, which is defined as the use of an improved drinking water source, which is on premises, available when needed, so insufficiencies are not experienced in drinking water, and free of fecal and chemical contamination. And we're using mixed data, of course, for this. When it comes to drinking water quality, we only use data on drinking water contamination using E. coli as an indicator. And so, as with many of the other SDGs, when we look at a global scale, there are many data gaps. Despite the impressive efforts from the mixed team and also other countries to collect this information at a household level. And our work has focused on addressing these data gaps on a global scale, and also we're going to present some work where we're starting to look at it at a higher resolution scale, so looking at settlement levels. So for the context, I'm going to describe a study which we recently published, which addressed these data gaps at a global scale. Here we used mixed data from 27 different countries and combined it with geospatial data derived from Earth observation and predicted the indicator safely managed drinking water services as an outcome across low and middle income countries. And we then also modeled the different subcomponents. So we modeled independently fecal contamination, drinking water availability, accessibility, as well as the type of drinking water source, if it was improved or not. We also demonstrated in which parts of the world, so this is a map used with the three subcomponents, accessibility, fecal contamination, and insufficiency. And so we show in which parts of the world which of these subcomponents is the limiting factor. So if it's E. coli contamination, which was there, so fecal, which is an indicator here for fecal contamination, it's in red. If accessibility was reported to be the major issue in a region, it's in green here. And if it was availability, so that people report experiencing insufficiency, then it's in blue, and otherwise it's a combination of these. And so something we were very interested in is how these different geospatial data sets, how they capture variations in safely managed drinking water services, as well as the subcomponents. And so we took an agnostic approach here. So we took a lot of variables. We started off with around, so let's say around 100, you have to check in the paper the exact number. But it was a large number we started off with, and then we narrow it down to 39 different variables. And here we just see the grouping. So which were the most important indicators for the different outcomes. So we see that human layers, for example, the fraction of urban built-up land or population density were the most important for predicting the water source type, as well as its accessibility, so if it's in your house or not, or on premises or not. And then we saw that for fecal contamination, the climate variables were actually the most important, so like average temperatures, information about rainfall, seasonality. And when it came to drinking water availability, the indicators which describe vegetation coverage were the most important. And so this is hypothesis generating. We cannot say that these are causal relationships, but we also base the work we're doing now also on these findings. So this study had several limitations, and they were mainly due to limitations in spatial resolution of data available. Yeah. So we aggregated at subnational district levels because we didn't have the exact locations of the household. So we calculate the percentage in a region of people who don't use safely managed drinking water. This is already great, but because we couldn't use the exact locations, we also couldn't use the dates. So the temporal component is also fairly imprecise. So also that, for example, the climate variables we use are annual long-term averages. And so this was the start of a collaboration, a closer collaboration with the GIS mix team, when they, in 2022, I believe, started releasing the coordinates, the coordinate locations of the surveys. And so I will hand over here to Nazim to explain this initiative.
I hope you can hear me. Yeah. Hi everyone, my name is Nazim. So as Esra said, in 2022 we started on releasing GPS datasets for mixed surveys. But this initiative, we started working more on this since 2021. But at the earliest stage, since 2005, when we started with the third round of mix, we were asking countries to collect GPS data for all the mixed clusters. However, we never engaged on releasing these data sets since we started with the initiative that we called MixGIS in 2021 on making geospatial data available, but prioritizing the respondent protection. Respondent protection from identification is a key aspect for the whole MIX program, and the same is for the MIX GIS initiative as well. But in the same time that we are protecting respondent from being identified, we are making geospatial data available. On this way, we are adding the spatial analysis of mixed data. There are three main projects within the MixGIS initiative. The first one is GPS datasets, and then we have survey boundaries and the geospatial covariates. So GPS datasets are mainly showing the anonymized displaced cluster locations of mixed survey. And then the survey boundaries are showing the boundaries of the survey, meaning the boundaries at the, usually but not always, at the national level and sub-national level when we have the sample certification. And geospatial covariates, where we are linking the mixed cluster locations with external data coming from different open sources, like on population, on climate and environment, and all the topics. Like in each mixed cluster, you have the estimated population under 5, or you have the minimum temperature, maximum, and some other indicators. So what is most concern for this analysis that we are presenting today on WASH is the data source of cluster locations. So the main data source in mix are in 3 different types, and we are showing them here with pictures, with maps. So it can happen that in mix we have, depending on the data availability in countries, it may happen that we have the boundaries of clusters, or it can happen that we have only one pair of coordinates per cluster, and it can happen like you have the household locations surveyed for mix. So these are the main 3 data sources of cluster geocodes within our program. And for this study, we worked for Lao. So the analysis are done for Lao PDR Mix 2017. And the data source for this survey was cluster centroid. So we had only 1 point per cluster. In either of the formats for the cluster geocodes, we use the same methodology on anonymizing the data sets. The methodology that we use is the global gold standard developed and implemented a few years ago from the DHS program. We are using almost identical methodology as them. So in bullet points, we are showing the criteria or what we do when we are displacing the cluster locations. First thing to do is to determine the cluster centroids. So if you have boundaries of the cluster, or if you have household location and so on, the first thing to do, the first criteria of anonymizing the data is to determine the cluster centroid, and then we displace it at a random angle and at a random distance depending on some additional parameters like the area type of the cluster. Even after the displacement, the cluster must remain within the same administrative area. So for this research, for example, Esther didn't have access to the original location of the clusters, but as long as they are within the same administrative area, we can do very good predictions on WASH analysis. So I will hand it over again to Esther to continue with Lao analysis. Thank you.
So this is so it was part of a pilot study. So the first country to release the data was Lao PDR, and we decided to use this opportunity to see if we can estimate safely managed drinking water services, as well as the subcomponents at higher resolution levels. So in this case, we look at settlement levels. I also want to say this is work in progress. So we've been confronted with a lot of different options for doing this. So for example, what are the outcomes to predict? We now decided to go for settlement levels, but there are also different options of projecting, let's say, at a 10 by 10 kilometer grid. There are lots of different options, and I'm very open for discussions because I've heard that some of you are working on similar projects. So, and this has not been published yet. This is a study which we started with Lao, which is a special data set because it's imbalanced. So as you see here, we have the cluster locations, and the majority of the data shows that safe drinking water, or drinking water is not safely managed at a household level. And so this is a special case, but our, let's say, larger aim would be to produce a pipeline or a method which can then also be applied to other countries which may have a different distribution in data. So we adopted a similar modeling approach. So we use random forest models, which are ensemble machine learning models, to predict. In this case, it's a classification. So we're looking at, is drinking water safe, yes or no? Safely managed, yes or no? Compared to what we did previously, which was a regression. So we're looking at the proportion of people. And here, in comparison to the previous study, we put more attention on understanding, so on interpretability of the different layers. So how, for example, the different features may also be correlated with other household survey data. And we also try to predict using household survey data. So these are some differences. We use, in both studies, spatial cross-validation. In this case, we leave one district out every time to account for spatial autocorrelation. Yeah. So here I'm showing some clustering of altogether the household and geospatial variables which we selected. Maybe I say one more thing to here. So the geospatial variables here also had different criteria for the selection. So we put an emphasis on using layers which are updated temporally on a regular basis. So theoretically, one could do future predictions. So for Laos, there's data which was collected in 2023. And this we use from 2017. So once that's released, we would also want to see, is it possible to make predictions for surveys which are collected, let's say, at a different time point, which, for example, might not collect E. coli data. So here we can see some clustering of the household survey variables which we believe would be important for modeling safely managed drinking water services. So we see, for example, one cluster is living area, which is urban-rural, was correlated with overall friction, which is modeled mainly to do with elevation, so how long it takes you to walk somewhere. But then we see it's also correlated there with elevation. Then we see that there are also several, that there are also here a clustering of the wealth score with, for example, nightlight intensity and urban built-up coverage and population density. And then we have clusterings of different environmental variables as well. Yeah, exactly. So we have, for example, we use the survey month. In the case of Lao, we only had samples from 4 months. One of them was in the dry season, the others were in the wet season. And so there we see associations with the month and the temperature. So the performance currently using the method we're using is, so it's better than average. So we have an AUC of 0.75. 0.5 would be like a random estimate. And so, but we're still not achieving the performance which has been reported in other studies which use these approaches. We're using this fairly conservative spatial cross-validation method, but I believe that this may be also due to the imbalance in our data set. So it's very, so we have like our positives are safely managed, and it's very difficult to predict where it's going to be safe because most of them are not safe. So it's really hard to capture those few which are safe. So yeah, I think that I've seen there's other approaches for dealing with imbalanced data sets which may be more appropriate. So either weighting or yeah, doing bagging where you have a more representative data set than which you're using. And so what we also did is we also ran the models using the displaced coordinates and then also using the original coordinates. And here we see that the performance is fairly similar. Surprisingly, it's slightly better with the displaced. I believe this is due to the, like, there will be a range. So it would be interesting also to, so the displacement, there's a randomization process. So I personally think it might be interesting to look at different displacement options, and there would be a confidence interval, and some would be above and some below. So that's would also need some more sensitivity analysis to look at this in more detail. But we see that there is no negative effect of the displacement currently. And then when it comes to the importance, we see urban built-up, as in previous models, is the most relevant. We also see that between using household and geospatial, and only geospatial, there's not a big difference in performance, which is also similar to other reports using these approaches. So then we predict, so we can have maps at different scales. These are outcomes. Here we project for settlement levels, but yeah, there are different options of doing projections. We also actually project per month because we matched our data with a higher resolution temporal. So you could even predict per day. We now just do averages across the months where data was collected. But yeah, the climate data is at a high temporal resolution. And so yeah, when we look at the subcomponents, we also see then when we do predictions for different months, different trends which align with our expectations. So for example, in the dry season, it's less likely to use an improved or an accessible source. Insufficiency, we don't see much variation. In the wet season, the probability of using a contaminated source is higher, and that also aligns with research or with literature to a certain extent. I mean, there's also variations in patterns in fecal contamination in relation to climate, but yeah. So we, as a conclusion, see these approaches as being very promising. I think there's a lot which can still be investigated, looking into how we can use geospatial data sets to fill data gaps on household survey estimates for indicators. And we can see that for safely managed drinking water, so for the WASH and the subcomponents, that this is working, and we will continue to look into how to improve these models. We also see that there seems not to be a negative effect of the displacement of the coordinates, and we are looking at these seasonal trends, and it would be very exciting to look at when we apply these methods to other countries if we can replicate. So do we also see these seasonal trends, and also to see how the models perform when the distribution of the data is different, so if there's a more balanced data set. Yeah, so I thank everybody who's been involved. We have had many, these are contributions for this Lao study. We've had many contributions along the way from people in the sector, also for the previous study we showed. And yeah, thank everybody who's been involved, and also the data sources which we've had the opportunity to use for the collection. We also thank.
Thank you, Esther. That was exactly 20 minutes. You leave it to these WASH people. They will do everything exactly on time. I'm shocked. Can I invite our next presenters for the presentation on spatial variation on curative child healthcare utilization in Sierra Leone, integration of routine health data with household surveys. We have Pamela Bockarie of University of Southampton to present on behalf of herself and co-authors.
Hello everyone, my name is Pamela Bockarie and I'm a PhD student at the University of Southampton. And I started last year, so I'm still new in my research. And so today on behalf of my co-authors, my supervisors, Wright, Amos Channon from the University of Southampton, and Osman Sankoh from the University of Management and Technology, Sierra Leone, I want to present our research titled Spatial Variation in Curative Child Healthcare Utilization in Sierra Leone, the Integration of Health Facility Assessment Data with Household Surveys, the mixed data. So the picture you're seeing, you see lots of pictures today. the photo you're seeing on this first slide is showing a billboard in one of the rural districts in Sierra Leone, and it is promoting exclusive breastfeeding for mothers. That is giving children 0 to 6 months just breastfeeding, no water, no other supplements. And the map there shows the under 5 mortality rate by district in Sierra Leone from the 2019 DHS data in Sierra Leone. As you can see, there's variation between the districts, with both local districts having higher under 5 mortality rate. So for this, my presentation today, I will go through the background, research questions, data and methods, and preliminary results. Like I said earlier, the research is still it's in its very early stage, so I'll just what I've done so far. So as a background, Sierra Leone is located in the west coast of Africa. It is classified as one of the poorest countries in the world, although it has the potential to be a wealthy nation. And it has been grappling with so many health problems, and it has high child morbidity and mortality rate. So due to these problems, the government has been implementing lots of strategies and programs to support the survival of children in the country. And one major one is the Free Healthcare Initiative that was launched in 2010 together with the development partners and donor agencies. There's been some improvements in the health status of children since then. And the healthcare utilization of children has also improved, but there are also some areas that are also lacking in terms of the utilization of healthcare. I remember in 2017, I was part of the mixed team because I used to work for Statistics Sierra Leone. So I was a supervisor for the 2017 mixed data collection in Sierra Leone. And one of the things that moved me into my research was that I was responsible for doing verbal autopsies. And while interviewing mothers, it was very, very emotional, you know, to talk to mothers when you're asking them the cause of death for their children, to find out that, you know, they just died because of fever or convulsion or diarrhea, you know, preventable or treatable causes. So that moved me, you know, into thinking about this, my PhD study. So for this study, I hope to explore the interplay of health facility characteristics with healthcare utilization in order to understand why health facility use is lower in some regions and than it should be. So in order to do this research, we are looking at various research questions. So we're finding out how healthcare utilization for child curative healthcare services vary between the regions, and the association between socioeconomic variables and healthcare utilization, as well as the healthcare facility characteristics, because you also find out the health facilities will be there, but then do they have the quality, the metrics, the things that should ensure quality health service delivery? Are they available? So in order to answer these questions, I'll be using data from the multiple indicator cluster survey for 2017, and as well as the service availability readiness assessment data. So the SARA is a tool, an assessment tool that is supported by the World Health Organization. And the last assessment that was done in Sierra Leone was in 2017. It actually captured all of the health facilities in the country. So it was the first national health facility census that was done. So I hope to link it together with the mixed clusters. I was fortunate to have the GPS coordinates from Nazim, so I have the mixed clusters, and we're hoping to spatially link them to see how health facility characteristics interplay with child healthcare utilization. So I'm focusing on children under 5s, and I'm also focusing on 3 common diseases, that is fever, diarrhea, and acute respiratory infections. For now, I've just done some preliminary descriptive statistics, but the methodology that I hope to move along with is to do multi-level modeling, since the structure of the data is hierarchical in nature. So we'll do multi-level modeling and then also do spatial linkages of the data in order to see the geospatial patterns of both the health metrics and the health care utilization and socioeconomic variables as well. So a study protocol was done in August on the open science framework to just ensure best practice for research integrity and also transparency. So this was approved on the 4th of August this year. In terms of the summary of the variables, so my outcome variable will be the child treatment seeking as a health facility for the 3 common diseases, and I'll also look at some socioeconomic variables such as the wealth index of the household, the age of mother, child of mother, educational status, to see how they affect child healthcare utilization. And also, we hope to also include other explanatory variables like distance, distance to the nearest health facility. So with the mixed clusters, when it is integrated with the health facility SARA data, we hope to see the distance from the mixed cluster to the nearest health facility and things like that, as well as also the exposure of the mothers, mothers to mass media, like listening to the radio, reading newspapers, etc. Oh, and also for the sample. So the mixed sample for 2017 captured 11,764 children under 5, and out of those, 2,994 reported having at least one infectious disease. We hope for our multi-level modeling to exclude those who did not have any disease because it does not pertain to a study. And those who sought care were 2,256, and those who did not, 735, and those who went to health facility were 2,075. So on the mixed questionnaire, the health facilities, we focused on the options from A to, I think, M or N or something like that. So things like seeking, self-medicating, or buying from a drug peddler, or buying from a pharmacy were not considered under this analysis. So the preliminary results show that by age, children 6 to 23 months are more vulnerable to the prevalence of diseases, although they also seek advice for treatment and also utilize a higher proportion, health facilities when they're ill. And also it is also interesting, but it goes with published literature, that children 0 to 5 months have a lower prevalence of the disease. As it is common, as it has been shown in the literature, that children 0 to less than 6 months are exclusively breastfed, and also they are protected from the immunity of the mothers. So this map shows the general service readiness for Sierra Leone from the SARA 2017, and you can see from there that the readiness, Sierra Leone, the health facilities are not that very ready, like they are like between 54 to 60% ready in terms of health service delivery, indicating that a lot needs to be done to promote child health care in the country. And the health system generally is really not so good. So a regression, binary regression model was done, first for fever, just for children with fever. And initially, just with the fever prevalence, most of the variables were statistically significant. But when it came to health utilization, they were not. Just like for the region, where in the southern region is marginally significant compared to the eastern region, which is the reference. And then for wealth index, the poor women were marginally significant to the poorest category. But then most of the variables did not prove to be statistically relevant. So we're also hoping to do multi-level modeling to see some of the variations that can be within the groups. In terms of geographical analysis, it is seen that there are some variations in the regions and also in the urban-rural status. It is surprising to see because, like, normally the urban areas have higher access to health facilities. They have improved health facilities in terms of larger hospitals and more facilities in the urban areas. And as a result, there should be higher utilization proportion. But then for this analysis, it's noticed that the urban areas have lower health utilization compared to the rural areas. And in terms of region, the western region accounted for lower health facility utilization, which is also surprising because in Sierra Leone, the western region is predominantly urban because the capital city is found in the western area urban district. So it is also surprising. But there may be several reasons to that, but one reason may be because of the residual impact of the Ebola virus disease that happened in 2014 and 2015. So maybe because of those impacts, people were scared of going to the hospitals and things like that. So they prefer to self-medicate or go to the pharmacy than seeking healthcare in the pharmacy. That can be a possible reason. So in terms of districts, for health facility utilization, it was also noticed that for fever symptoms, it was also noticed that both districts in the south accounted for the highest utilization rate. Whereas the western area urban, where Freetown is the capital city, and also Moyamba accounted for lower utilization rate. So it is hoped that when the data sets are linked, we'll also look at data sets from things like factors like health metric factors, such as some of the things that are contributing to these variations. Is it because the lack of essential medicines? Is it because the hospitals lack qualified or essential medical staff? Is it because they don't have basic amenities and things like that? So we also hope to integrate all of those data sets to find out all of those reasons as we get along. So in terms of the main types of facilities that are used for common diseases for children, according to the mix, it was found that the government health center and the government health post are the most common among the districts. It is the predominant primary care facilities that are there, and they are mainly found in the rural areas, so it is expected. And western area, urban and rural, have higher government hospital utilization compared to other districts. So the government hospitals are like the secondary care, and they have better facilities. They are found mainly in the urban areas, so it is also seen. Another one that I found interesting is the government community health workers, the CHWs. So these are workers that are recruited from the communities They don't have formal medical training, but they're trained by the health facilities to provide like first aid treatment, first aid cares, especially for those communities that are very far from health facilities or live in very remote or bad areas with bad roads and things like that, so that at the end of the day, these CHWs can provide care to primary care initially until people can seek a health facility for further consultation if it is needed. So it is noticed that they are fairly low in most, in almost all of the districts. Maybe for Puja, that is a little high. So in summary, it is observed that children 6 to 23 months have higher prevalence rates for fever, ARR, and diarrhea, with corresponding increases in seeking advice or treatment, as well as utilizing health facilities when ill. And as I mentioned earlier, the regression model that was done was able to show significance between the socioeconomic variables for the prevalence of disease, but it was not the case for the utilization of health facilities for the symptom. And there's also wide disparity in the utilization seen by region, as Western area region had lower use compared to the other regions. Like I said, next steps, this is just initial analysis, so I hope to go further in depth, as I continue my PhD, and hope to see how the results go. Thank you very much for your attention.
Our last speaker for the sessions here, the first sessions on spatial analysis, is on KidSat, but I'm trying to find it right here. Satellite imagery to map childhood poverty dataset and benchmark. This will be presented by Makkunda Sharma of University of Oxford. I think maybe Makkunda is joined by colleagues, maybe not for the session here, but certainly online.
Will is here around somewhere.
Okay. Oxford colleagues, and Oliver from Save the Children is probably also around somewhere, because I know he will be presenting things. For those of you online, please submit your questions. I don't think we've received a single question yet, but yeah. Oh, this is Will right there. So kindly submit your questions, but over to you, Makkunda. Thanks. This is for clip-on.
So, this is a work in progress. We have submitted this to NeurIP's machine learning conference, and I would like to talk about this work here. So, we are basically building a dataset and a benchmark for machine learning models. So, this is a...
You have got on the camera. Can you see for the camera?
Okay. Okay. Our contribution, we propose a new dataset pairing satellite imagery and survey data on child poverty. We create a benchmark task which measures childhood severe deprivation, and the benchmark is to measure performance of machine learning models based on satellite image features. And we also implemented some baselines so people can test out the work, and they range from foundation vision models to specific satellite imagery based models. And we also release the code to create a dataset, create the benchmark, and run the baseline models. And I'll also, in the end, I'll show this can very easily extendable. So this was initially done on the DHS data, but it was straightforward to port it to mixed data. So it's a useful pipeline in a sense. So you can play around with different kinds of data sets. This is the link to the GitHub repository. So the dataset consists of, the initial benchmark dataset consists of 33,000 images, each based on 10 kilometers of 10 kilometers, based on DHS survey cluster locations. It's similar to mixed surveys. So basically each cluster has a coordinate, which is slightly jittered, as was shown in the earlier presentation. Image sources, we use Landsat 5, 7, and 8 depending on the year, and Sentinel-2 also from 2015 onwards. The dataset spans from 1997 to 2022, and it covers 19 countries from Eastern and Southern Africa. Okay, now talking about the benchmark. So what we want to measure here is severe deprivation in children. As per the UNICEF definition, a child is considered severely deprived if they experience severe deprivation in at least one of the following areas. Housing, if the number of persons per room is 5 or more. Water, if household uses unsafe water sources. Sanitation, if household lacks access to sanitation facilities. Nutrition, health and education, so on. All of these are questions in the DHS as well as mixed data. So these are very useful things to measure. And so the problem is these surveys are very sporadic, so not very frequent. So if we can build machine learning models, we'll be able to look at it at a finer granularity and much more frequently, and can have policy interventions. These are the corresponding variables which helped us build the benchmark. Tasks. So in the benchmark, we had two sets of tasks. Spatial, we would like to test generalization across locations. So where we checked 5-fold spatial cross-validation at the cluster level across the data set. The training data set was 80% of the cluster location, and performance was tested and held out 20%. Temporal, this is a slightly harder task. We would like to test generalization across time. So as for a particular set of years, the model was trained on, and performance was tested on the future years. So we trained on data from 1997 to 2019, and we tested the performance on data from 2020 to 2022. Prediction. So this is the baseline part of the project. So where these are the models we've used to do the benchmark prediction on the benchmark data set. Mean prediction, this is the simplest baseline, where we predict the training data mean at every location in the test set. Basically, we compute the mean of the severe deprivation at cluster location, and we predict that at this is better than a random baseline, because random baseline is of no use. This is slightly better. Second, Gaussian process regression. This also does not use the image at all. Input is latitude and longitude of the cluster, and the target is severe deprivation variable at the location. So here basically we are trying to see if there is any spatial correlation in the data. If the prediction can be learned just from spatial correlation without taking into account the satellite image features. Then mosaics. So this is a work from Harvard. It is a generalizable feature extraction framework for satellite images. So in this framework, you enter the latitude and longitude, and it gives you a general purpose feature vector, which you can use for whatever downstream tasks you like. The downstream task here was predicting the severe deprivation. So we use their API to get a feature vector for every location at the cluster, for every cluster location in our data set. And then we ran a ridge regression from the feature vector to the target variable. Now, slightly more particular baselines. So SAT-MAE, this is a popular satellite image-based machine learning model. So this is based on a pre-training framework based on masked autoencoder. So in this model, they use a masked autoencoder to predict a 1024 dimensional vector to encode every satellite image. They trained this on a dataset called Functional Map of the World, where they use sentinel images to predict low-level features like traffic, roads, transport, and so on. We use that as a baseline model, and we fine-tuned this on our task, where we appended a transformer head on the model to predict the 99-dimensional target DHS variable created from the survey. Finally, we performed ridge regression from a 99-dimensional vector to the target variable. And DINO V2, this is a general-purpose foundation vision model trained by unsupervised learning on a corpus of hundreds of millions of images. So this is basically unsupervised learning. To this, we use this model to get a feature vector for every image. And the model outputs a 768-dimensional feature vector. We fine-tuned this by appending a regression head to predict the 99-dimensional DHS vector. For final prediction, we performed ridge regression from the 99-dimensional vector to the target variable. This model was the best performing model on a data set on all our tasks. This showed like the foundation models learn more information which is useful in our tasks. Okay. These are the results. So these were the models, these were the benchmarks, and this is the performance. So the metric we used was mean absolute error in prediction of the severe deprivation. So for the mean prediction, it was around 0.3, and the best performing model got down to 0.18. So this, the performance is not very high. This shows this is a hard task and it is worth spending time on learning, working on this task. This is and measuring poverty is an important task. So this will be valuable. This will be a valuable benchmark, and general purpose machine learning models can also test out on this benchmark to see where they stand on a task like this. And application. So here, so we took a country completely outside the data set. So Kenya was not in the data set, and we passed. So we took the DHS locations and we estimated the severe deprivation variable based using our models. So the image on the left is what the ground truth is. The middle figure is what the performance was using the spatial training data set, which was trained on 80% of the locations. And the final one is the temporal training data model, where this model predicted using only data until 2019, and this is from 2022. So you can see this is slightly, the performance is reasonable, but it cannot capture outliers. The spatial model cannot actually capture outliers, while the temporal model can. We would like to investigate further on what leads to such performances. Similarly, we use the mixed dataset from Malawi from 2019-2020. Use the cluster locations from the Malawi survey to estimate it. So the image on the left is the ground truth data, and this is the prediction. So our model predicts a higher level of severe deprivation than what is actually seen in Malawi based on the mixed data. So this also shows the model is not generalizing entirely very well, because this data is slightly different to the DHS data and it is overestimating poverty there. But what this shows is the only change we did was just fed in the mixed survey, and our model was our code was able to perform, run and so on. So this is a useful pipeline, and in future work we would actually like to train on the mixed data as well to improve performance here. Extension and future work, and we would also like to create models to estimate all the 6 sub-components of poverty, like education, health, nutrition, sanitation, instead of just the final vector. And also we would like to add another harder task like spatial generalization, which didn't happen, as you had seen the Malawi data, where it was given a country completely out of the data set. It did not work very well. So we would like to formalize this. And finally, as I said, also training on the mixed data instead of just evaluating on the mixed data. Acknowledgements, these are all our funders. Thank you. Any questions?
Thank you. You were very fast as well.
Sorry. Slightly nervous. This is my first presentation.
Thank you. No, that's always good to be fast. We have plenty of time for Q&A. Are there any questions in the room? And I think we can be quite generous with time, so please don't hold back. Yeah, because of the microphone situation, and we can't really pass back and forth, I kindly ask you to ask, what should we say, short, simple, sweet questions that I am able to repeat. So when you start talking about satellite and all the beautiful acronyms, please bear with me because it is not my forte. Any questions from the room? I see here and here. Let me go here first, if you don't mind, because there I can at least pass a microphone.
Thank you very much. So I have questions for the last 2 presenters. For the very last presentation, my concern is the resolution of 10 kilometers.
Yes.
Just to give a precise example, horizontal line Malawi would be 160 kilometers, so it's 16 squares. But when you show us the graph, it's very smooth. So when you are softening it, it's really aggregating too much. Another example would be Nairobi is 40 kilometers diameter, 4 points for all Nairobi. So how much are we losing information and what are we doing to compensate? In the case of the presenter number 2, the challenge I'm seeing is people, the use of the hospital and the wealth of the people, because One thing is to have a hospital near and you can have access, or you are rich, so you are in a better place that has a hospital, and because you are there, you might not need the hospital so much because you are already rich, so you are in a better side of life, let's say. And we see that contrast in one of the paradoxes that was shown in the last slide, people that have high access but low utilization. So how are we making sure that the wealth is not what we are measuring when we talk near the hospital rather than the clinical part of it?
That was some difficult questions to start off with. It's too early. I think we can take there. I was thinking you were there before.
No, I came here because it's a technical question.
Yes.
So probably it's better if I say myself.
Yeah, you see.
Yeah, thank you very much. Wonderful presentations. My first question is for the first ones. Congratulations. But I was wondering if there is any reason because you choose random forests instead of support vector machines or relevance vector machines, or more generally, is there any reason for choosing bagging instead of boosting when you made the machine learning methods? Just a curiosity. And for the second presenter, beautiful presentation. But I was wondering, isn't a problem the fact that you are not considering factors, cultural factors, as the lack of access to health facilities for reasons other than the distance, for example, because mothers prefer to self-medicate, or mothers prefer to not go there because of Ebola, because that is causing omission variable bias in the regression. So I don't know, how are you thinking about considering these factors into the multi-level modeling? So basically, those are my questions. Thank you.
Thank you for coming up here, because I would never have been able to repeat what you just said. I have some questions too, but I think maybe we should let our presenters answer these before we move on.
Okay.
I'll pass to you to begin with.
Yes. So first question, so we have to use a slightly broader area because of the jitter in the original data. If we go very fine, we might actually not be taking the image of the actual area, the survey. It's a reverse question. So if we increase the area, we are obviously losing some information, but smoothing is also a feature of these machine learning models. So in any case, there would be some smoothing happening. To mitigate for this, I would like to think about it. I can get back to you later how to mitigate for this.
All right, perhaps, yeah, while you travel, we can hand over to here.
Yeah, thanks for the question. So the main decision for taking like the random forest was based on previous studies. So I didn't run these models with alternative like XGBoost or something else, but we saw that performance for similar outcomes, for example, for E. coli contamination, was the highest using household survey data. So collaborators did a study using data from Ethiopia, and there the random forest performed the best, so we decided to take this approach. Yeah, but yeah, we could also try and see. Yeah.
All right, Pamela, please.
Thank you very much for your questions. So the one on wealth, yeah, I agree with you. Like wealthy people normally, they don't go to the primary healthcare facilities, so it's going to be a challenge. But we'll find a way to see how we can address it, especially when it comes to utilizing the health facilities. As is seen in the utilization chart that I showed, the wealthy people, those in the urban areas, prefer to go to the private health facilities, and yeah, the poor ones obviously use the basic ones like the community health posts and the health centers. Thank you for your comment. I'll take note of that. And yeah, thank you very much also for your comment. You mentioned about, what did you mention again?
I was wondering.
Okay, about the cultural, the cultural aspects, So it'd be really nice to integrate that into the multi-level modeling. And like I said, it's still in its early phase, so it can be considered. I hope there'll be funding to do that so that we can do some amount of primary data collection so that we can feed that into our model as well. Also, maybe we can also consider the attitudes of health personnel and things like that, together with the behavior, the cultural behavior and things like customary beliefs of the people. Thank you very much.
Thank
before you go, Pamela, we have a question online for you as well, so perhaps we can read
Coming
that.
over here. Yeah, why don't you ask it? Ask us.
Right. So Pamela, the question is from Robert B. So he's saying, great to see these preliminary results. I'm curious to know if there are any geospatial layers you could introduce related to Ebola to test this hypothesis, to explain the differences in service utilization.
Okay. Thank you very much.
Hold on.
Thank you very much for your question. I think it'd be very interesting too to see if we can have geospatial data sets integrated on Ebola integrated to the research. At the moment, I've not thought of it, but it's a thing of consideration. So thank you very much for that. I'll take note of that.
There are more questions. Let me just add, while I have the microphone, I do have some chair privileges, and we have plenty of time. I mean, there are some very interesting surveys that have been used in the analysis here, right? We have the Sierra Leone survey, which is post-Ebola outbreak, which had additional factors included. It was the first Mix-6 survey, when it's the first survey in the round, which means that people like me are running around screaming to get everything right. It's a big mess when we start a new round, no matter what we do. Very, very tricky survey. And then Malawi survey, which was broken off in the middle because of COVID, right? So the post and pre-COVID situations that we were trying to manage. Very interesting circumstances. There were many hands in the room, so I will not ask any questions. There was here. Yeah, please go ahead. Yeah, I'm coming around. It's a lot easier. There you go.
Thank you very much, Pamela. I just had a question about the variables you left out regarding the use of dispensaries, and linked to that, the population density, because I was very interested in your result why urban areas had higher access. So the western areas had higher access and lower utilization. So if you think about population density into urban areas and the demand for health services and facilities, and if there are other avenues for mothers to seek for health for their babies, and linked to that also you have what's it called now, medications that are not illegal medications. Yeah. So I can't remember the name now. And how could you include that in your regressions, or are they even important in the first place? Because I think these are all factors that are linked to assessing health services for mothers in institution.
Yeah, I have a couple of questions. Thank you. Thanks so much. There were many to Esther, actually. So I was really intrigued in the final slide, the sort of thinking about the purpose and the use of these models and the prediction. And in one of the slides, you rescaled some of the cluster level predictions that you've made to an admin 2 level. So I just wondered this thinking around representativity of at that level, and whether or not your predictions account for that, or in any way, or any of the thinking that you've been doing around that, because I know that that's some of the limitation in some of the work that we're doing. And then also I wondered if you could just talk a little bit more about the kind of temporal validation, so whether or not you can use predictions from a given year in another, and how that's done, and just to understand that a bit more.
Should I pick up one more, because I saw that the chair of the entire event had a question for that.
Okay. I'd like to thank all the presenters for some excellent and really interesting presentations, and I've got loads of questions, but I'll just stick to a question which is for the first and last presenters. So I'm really glad to see the use of more modern techniques for machine learning. Random forests is obviously much better than older binary regression tree models like exhaustive shade. And they're much better results than, say, Facebook's initial attempt, which was based on measuring poverty using, I think, mainly where the location of phone masts was the main loading. But Bristol is a national centre of excellence for multi-level modelling, and my colleagues in those who work on that would probably argue that it's not clear that these machine learning models will produce better results than more traditional small area estimation models like hierarchical Bayesian methods, which have mathematical properties we understand better. I have colleagues in geographical sciences who are international experts in geographically weighted regression. They would argue that the relationship between the predictor and outcome variables may vary over space, and the machine learning models, I think, are stationary in that they fit a global or national model to all areas without allowing the variation between the predictor and outcome over space. And I just wondered how a geographically weighted regression or a traditional small area restoration methodology would compare with the results that you've got from the machine learning models.
You may start. Hold on. No need to just hold it. I will check it.
So we actually, the small area method was a baseline that we compared it to, and the performance of the machine learning model was better. It was non-trivially better than just the small area estimation method. So, and both the machine learning models were better. And these machine learning models are no longer stationary in a sense. So for example, the SAT-MAE model we use takes in temporal information. And so they're no longer stationary, and they're incorporating these informations. So.
All right, thank you. Probably Esther has something to say, I believe. Over here.
Yeah, it would be really nice to have a conversation, because I feel it's probably better for the back and forth that you also then, I probably forget things which you've asked. But yeah, so, I probably already forgot. So it was about first the comparison of the different models, right? So we didn't compare in this, but I also agree that probably to a certain extent, I think using other statistical models can generate similar performance, I would say, in estimates or accuracy. One thing which, when we took this approach, we were focused on, it was also in understanding the contribution of these different geospatial data sets which are derived from Earth observation for outcomes. So we took this agnostic approach and took a very large set of features with a lot of different characteristics and scales. And I think here the models we use are more robust for dealing with like large, so we had in our first models over 100 predictors, and our data set isn't massive. So I think with them, with let's say generalized linear models or with multi-levels, this would not be possible. So I think that was one of the motivations for this method. And yeah, about kind of the feature importance or how it varies spatially. So one thing we look at as well in like a sensitivity analysis is where is this model applicable based on the predictor values in different areas. So where, let's say, the values really range or, let's say, much higher than in the place where we've trained, we mark, so in the supplemental, for example, there are maps showing like, okay, in these areas, the predictors are quite different. So if we train there, we're not certain that it's actually applicable there. So, yeah, but we can have a conversation. Yes, exactly. And then, so we had also questions about the different levels and representation. So I also think one sub-analysis we did for the Laos data, we compared how well our predictions compared to averages at a settlement admin district level. So like, if we take the average, is it a better predictor for at a cluster level or not? And it was actually, so just taking the average in the district was very similar, which is to our prediction. So having a very, very basic model, which is just an average, was very similar. So actually, like this complex modeling method in our case, you could say it doesn't really, maybe pay off. But I'm not sure if your question was a bit different. It was about that comparison. Yeah.
Yeah, I guess it would be more about if you then, so long if that's at the admin 2 level, because that's at that lower level of disaggregation, is that even if the cluster level averages in a sense, those clusters would have been sampled within that area. So it's kind of like a sampling question. So, but the sampling frame would have been decided at a level above that.
Yeah.
So it's just, is that sufficient for sort of justifying that it is representative or not? Especially if decisions are being made on this.
Yeah.
Yes, that would just be.
Yeah.
But
I think it's a really tricky question, and I think this is something to look further into, like how representative are these and how could you rely on such estimates if the survey is designed at a national level, right? It's kind of this context, or for like higher level districts, right? Yeah. And how do you aggregate, maybe if you have a high resolution estimate, like how do you then generate, let's say, district estimates? Is it kind of this discussion, right?
Yeah.
Yeah.
Yeah, and maybe some of the methods from the
hierarchical. Yeah. And for the temporal one, so we just did we do a spatial cross-validation for spatial. So we leave one district out and we train on, let's say, 17 districts, see how well it can predict for that. And for the temporal, we do the same with months. So we train, let's say, on all the months which are in the wet season and try and predict for months in the dry season. That's the way we did it. But
I'm sorry, just to say we've got some feedback online that they can't hear very well.
Because I decided to not use a microphone for a rebuttal here. So,
so if we can all remember to try and use microphone, and ideally if we could stand in front of the camera, that would be great as well. In an ideal world, I'm not.
I will now go to the cheap seats in the back because they had questions. While I'm walking there, this displacement that we do in Mix, DHS, and others, don't come here to me. You can go up there if you want. It bothers me, right, because we take our original cluster location where people live, right, in the settlement, and then we are displacing them with a high likelihood to where people don't live. Meaning that we already have a massive design effect on, say, wash indicators that are based on that the facilities are where people live. And then we are pushing them out. And I struggle to understand how models can effectively integrate that. But obviously you are smarter than me. No, I would like to, in honesty, I would like to displace in a different manner than basically just on urban-rural location. And I think the world is moving towards a different type of displacement that have to do with population density, for instance. There were questions back here. Tom, you were there.
Yeah, thank you very much. 3 excellent presentations. Esther, on your presentation, I was quite intrigued, to Beau's point, how there was very little difference in performance between with and without the displacement. I don't really understand that, but that is a big question for me. But you described one of the main limitations of the dataset in Lao being the sort of binary nature of the safe, not safe. But actually, that dataset does have degrees of safety, so the risk of contamination. I wondered, did you think about looking at that using the same dataset? And running the model again, using the E. coli counts for those households where it's collected. And then Patricia, I think this is really interesting. Your challenge of trying to link household level data with healthcare facility level data is something that I don't think anyone has solved. So good luck with it. But I think it's really important. I mean, we can make assumptions about which healthcare facilities households are using based on where they live, but it's very hard to actually test that hypothesis. But you talked a lot about household data. You didn't talk much about the healthcare facility data that you get in Asara. And there's actually a lot there on the quality of those facilities. And I suspect that will have a much bigger impact on whether people use them than anything to do with Ebola or other things in the past. The current situation of those healthcare facilities, I think you could dig into that data and particularly for the types of infrastructure and the types of services that are required for ARI fever and diarrhea. I think there are some really strong indicators in Asara that are already there. Thanks.
Thank you.
Jay, you had your hand up. Would you?
Thank you, Bo. No, I have a small question to Esther. One is, as Tom mentioned, you have used both original coordinates and displaced coordinates. So my question is, are we supposed to use the original coordinates in our analysis? Because that is not made public in any way. So I think we have to be a little bit careful in terms of what kind of data we use for our analysis if there is no special permission to use that original coordinate for, okay, we have access because you worked closely with the mixed team. But otherwise making a presentation, I think we have to be a little bit careful there, yeah, in terms of the sensitivity of the data use and data protection, all that. So that is point one. Second is whether this good, excellent research was kind of shared with the Laos and presented to them for kind of taking this into real kind of policy action, whether that action was happened. At least I'm coming from that region, so I haven't heard anything happened on that front. So it will be good to do that. Otherwise, this will be another research sitting with no action taken on, right? And another is a general question to all these AI model experts. I am a big zero when it comes to AI model. But my question is, we hear a lot about training data and then predicting AI models to generate data in the interim. So my question to those experts are, what kind of frequency in which you need the training data to perfect your model to get a kind of reasonably good prediction in the interim period. And one more thing related to that, are we kind of spoiling the kind of system of strengthening the admin data by bringing AI as a kind of replacement? So good to hear some of the reflections and views from that point, because I personally feel that strengthening admin data systems is very, very important. And even though we have kind of AI model predictions kind of things coming up. So that is another one. And a couple of, one more comment actually for the Sierra Leone presentation. I think when we are presenting the data, I think we have to look at a little bit more carefully in terms of, presenting the data, because I have seen number of, children presented at the end of the column, but that is not necessarily the denominator for all the columns presented in that table. So it's a simple thing, but I think it matters. So please be careful when we are, presenting tables and data. So thank you.
Thank you. Anything, one more at the back before we invite the speakers to respond?
Thank you. So my question's for Pamela. The acute respiratory infection, diarrhea, and fever questions don't have any indication of severity. So I'm wondering how you accounted for that in the health-seeking model and why you chose to use those indicators as opposed to something like immunization data instead.
Thank you. Maybe I can stop by you, Pamela, and you get the first chance.
Thank you very much for so many comments. I appreciate them, and some of the questions. So my interest is looking at common diseases, and fever, like malaria, is very common in Sierra Leone, and one of the major symptoms of malaria is fever. So yeah, that's why I'm focusing on it. Like I said, my research is early, so maybe I will look into immunization, because like it kind of is a preventative measure for some of those diseases, like ARI and things like that. So maybe that can be incorporated. But I'm focusing on the, these common diseases at the moment. Thank you very much. Somebody mentioned about pharmacies. Yeah, so I'll agree with you, because I remember me too, just after the Ebola period, I was a mother and I didn't go to the health facilities. Most time we just queue at the pharmacies, because it's, during that time, it was like, we felt safe because the health personnel were like at risk of having infection from the Ebola, and some of them were dying, so many people were scared at that time. But even also for convenience as well, because sometimes you go to the health facilities, you stay there long and things like that, and if your child is having symptoms of some disease, maybe you just go. But the disadvantage of doing that is that some of the people at the pharmacies are not trained, so maybe sometimes the drugs they give, they're not the right ones and things like that. So I am sticking to the mixed recommendations for the formal health facilities for this research. It can be maybe another form of research, to look at, the other informal health utilization avenues that are there for seeking healthcare. Thank you.
Thank you. While I'm walking over to the next presenter to respond, to your point, Tom, about connecting health facilities to households, you have an excellent database in Sierra Leone of all health facilities, right? And that is generally being quite positively updated.
So we have an excellent database that has also been updated by the Grade 3 program in 2021. So it is georeferenced and accurate. But one of the challenges that I'm particularly having now at the moment with the SARA data, because I've not done a lot of analysis with it, is that during the data collection, GPS coordinates were collected, but then it was only the latitude columns that had readings, and then the longitude, there were no readings for the longitude columns. But I'm thinking of finding a way to geocode using the National Health Facility shape files that we have. So there'll be a way of going around that. Thank you very much.
One of the things we're working on with Mix these days is called Mix Link, where we link admin data to survey data. It can be done relatively, it's a big word, easily with schools. There are good databases on where schools are, and we can ask, what school do you go to? Relatively easy. For health facilities, a bit more tricky, but it is possible, and there is something there. What facility did you go to? With the right ethical clearances and what should we say, taking care of all of these things, it might be possible to link data sets on this in the future. Eva is our responsible Mix link coordinator in New York, and she will tell you that it's not as easy as it seems, just so that you know. It looks really promising, but it's not that easy. Would you like to respond to anything or comment on anything? All right. I'll move over to Esther, because there were lots of questions for Esther. I thought you were chasing me. And thanks for going on camera.
So I took a few notes. Regarding Tom's question on E. coli risk categories, I guess that was what you were addressing. So this is something which came up recently when doing the subcomponent analysis on E. coli. So there was a master's student who was focused on this. And actually, to his defense, exactly this came up and was, we discussed it, and I think it would make sense because there's more variation in the outcome. So if we look at the different risk categories. So I think this is something which would make sense for E. coli as a subcomponent. What to me isn't completely clear is if we're trying to predict safely managed, there we have the strict kind of binary outcome where safe is only without any E. coli. So I guess maybe it would be interesting to discuss, are there other levels one could look at where there may be more variation for that? And then about the displaced and not displaced. So also to clarify how this was done, I never had access to the original data. This was Nazim who ran this analysis. And so the way it was done is we sent the code to Nazim and went through it together, and it was then run, like the model was run on the original data set this way. And yeah, we were also surprised that the results are quite similar. And maybe it's also important to understand how we sample the environmental data. So we don't take a point at the exact location of the cluster, but we also took an average and we used in rural areas a 5-kilometer buffer and in urban areas a 2-kilometer buffer. And those are the same distances by which the data is displayed. So there's already a spatial, they're quite close spatially. And also, maybe it would be interesting to look at how much the variable outcomes actually differ, because I think some of these variable outcomes, if we're thinking about, I mean, some might differ by 5 kilometers, but I think some of them might not differ a lot. So that could be one of the reasons why it's fairly similar. And then we had other comments on data protection, I noticed. Exactly. So maybe that was also connected. I'm not sure. I can't remember the nuances of that question. Was this answered in some way?
I can take
yeah, you take that one.
Okay, thank you for the comments and questions. First to Tom. I think Esther mentioned, I know Esther mentioned during the presentation that we are going to run this analysis on several displays done. So this is a work in progress, and we run the analysis from my side. So from the global mix team, we run the analysis in the original location of the data, and from Esther, she got access to the displaced one. So as a next step for us is to run again the displacement. So the tools that we use run the displacement randomly, and you can never displace the cluster in the same location, or I mean, you have to run it a million times to get the exact same displaced coordinate. So we are going to run the displacement several times and test how it works and see, maybe we just got lucky to have this in the first try, and we will see in the next ones how it works. This is it. And then for the getting access, maybe we didn't make it clear while we were presenting. As a mixed program, we never share, for GIS, we never share original data of cluster locations. We have access, of course, the government is the owner of the survey, and of course they have access to the data because they are owners. And then in the other side, we as mixed program have access to the data, but it stays only within the team. And we never share anything regarding the original location of the clusters. We did this just to show that the methodology of displacement is working or is not. At the first try, as I said earlier, it seems to work, so it's fine. But we still have to provide more reasons that this methodology is working or not. We have to prove it yet. Anyway, we are not sharing this with others. Even Esther, that is a good friend to us. And then the second, question was about presenting this to Lao. And of course, maybe Esther can answer to this one, but of course, they are aware of the research that is going on this.
Yeah, so I think the exchange with Lao needs to be strengthened. They are informed of the work we're doing, but we still need to discuss. And I think what's very interesting is that now there will be new data come out from Lao. So I think this part might also be the people who've been collecting this now. I think it'll be interesting when this is accessible. I believe it's not accessible yet,
It's not online yet.
Oh, it's not online yet. Okay. But as soon as we have access to it, we would also like to compare, and that maybe connects with questions about like temporal estimates. So using that also as a test set and seeing how well can we predict if we update all the Earth observation data.
I have two questions. I don't know if you want to cut it or I can.
Oh, and last one. Sorry, very last one. I would also highlight that these approaches, I don't see them as ever being a replacement for collecting data. I mean, our models are just as good as the data we have, and we already have very limited data, actually. Like, these models are based on very limited data, especially when it comes to temporal trends. And so I think it's difficult to update estimates more than every 5 years. And I think maybe we could see how we can bridge some of these data gaps. So I think identifying what are the needs and the data gaps and how these tools can be leveraged to fill those. I think that's kind of the way I see this supporting the work, but not as a replacement.
Thank you. Any more questions in the room? I know that you have two. Let me just say, one more there, one second. I just wanted to say on top of what you were mentioning, Jay, on communication with the data owner, the countries. We have just, I'm just flagging this, this past week, we have launched a new MIX website that now integrates the GIS data, which our previous website could not handle. So now when you request access to GIS data, it's the same protocols. You have to fill out an online form basically, but it sends out automated emails to you. Hey, have you remembered to submit your research to us, to the country? Can you please do that? And it is increasingly sending spam. And at the end, it will release your email address to all kinds of horrible internet sites if you have not submitted any research. So I'm just warning you, but we have set that also as a timer. If you haven't submitted research within 1 year, your email goes to the dark web. Okay? And I see a couple of questions for you, and then in the middle. Maybe I'll start in the middle because you have access to everybody. I'm coming over here. Can't come further than this. Yes, I can do it.
Thank you. Yeah, this is from Nazim, but also for you guys. So I just wanted to get clarity on how many GPS data sets are released from MIX and how many will be released, and will you be retroactively georeferencing any of them? And then a question for Esther. I hope a single question. In your global model or quasi-global model, it seemed like you only use mixed data. Are you going to be incorporating DHS and other surveys for that? Thanks.
Question, I will let Nazim answer that because that's his job.
Yeah, and it's good for you to run around the room. I think you need it. Yeah. So first, very few comments on just to continue what Bo said. We just launched a new MIX website, and there we have much more space for MIX GIS when you can request GPS data sets and survey boundaries, and soon, hopefully, the geospatial coverage. This is, I think, unfortunate for me because Pamela and others are recognizing me and mentioning my name, but then now in the new website, you are just going to click there, and you will get access to the data without remembering my name. So I'm sorry for myself. So for your question, at this stage, we have 15, so 15 surveys with GIS data sets released on our website. The earliest is from Kosovo, is 2013-14, the survey, and we have surveys from 2021-22. And we are working, so last year we started with the 7th round of MIX, and for all the MIX 7 surveys or all the MIX 23 surveys onwards, we will have the GIS data sets released. And I see both hands moving like this is what we hope. And we have some countries that the data restriction is a bit, and the data sensitivity is, it's more than in other countries. So maybe we will not be able to release some of them, but we hope that this will be very limited. And for the backwards, we are moving. Maybe I cannot mention a name, but we have a survey that from 2010 that we are trying to make. We are working on releasing the GIS data sets for that survey. So at the same time, we are moving forward and backwards. That is the comment and answers. And I had 2 questions for the 2 others, not for Esther. So for the 2 others, so Pamela, great work, and I hope, I wish you good luck on your research. I heard you saying that you are planning to calculate the distance between the household locations, so the cluster locations, and the health facilities. And Bo mentioned another initiative within Mix, which is MixLink, and where we are linking the, for example, the health facilities, education facilities with the cluster locations. And we are working in one survey in another country on linking education, so schools, with clusters. And I wanted to know what are your plans, what kind of distance are you planning to calculate? Are you going with air distance? Are you going with walking distance or driving distance? Because I think it's relevant, and we are testing how this is working if it's impacting the air distance. So if you take a straight line between the health facility and the cluster location, or you follow the road. And you mentioned the altitudes. I would like to know if you have plans on this. And for the Oxford guy, so you mentioned Madagascar, but in the Malawi, but in the second slide you mentioned 15 countries. I would just like to know your plans for other mix, if you are planning to replicate this work in other mixes.
Yes, we would like to replicate.
Hold on.
Yes, you would like to replicate the work in other mixed countries. So Malawi was a proof of concept, but you would like to train the model of the mixed countries and see what happens.
Thank you. Here.
Thank you, Nazim, for your question. Yeah, at the moment it's straight line distance that I'm looking at. Yeah, so it's straight line distance between the mixed clusters and the health facilities.
I think that not exhaust our share. We have Esther with a comment over here, and one more online, and then we close.
I just want to answer Josh's question. So we didn't use DHS, and we currently don't plan to. The major limiting factor for safely managed drinking water services is fecal contamination, so data on E. coli is what we're using, and I believe those are not that data is currently not included in DHS, which is why we went for the mix. Yeah.
All right. Last comment from online. I will add to Nazim's on our future plans for mix. As he said, we would like to release for all surveys. We've done some of the easy ones. It's a terrible mess when you open old data, obviously, when we have never looked at it. For the future, not all surveys will be releasing this because of restrictions in protocols of the government, but so far we have been successful in, convincing our partners to at least run the process, collect it, get it cleaned, let us anonymize it together for internal use. And I think that's the best, because then that data set is packaged, and when protocols may loosen in the future, it can then be released. So we don't have in 5 years to go back and start the process. So everything to be cleaned, even if it's not released. Would you like to read the question?
So I believe this question is for Pamela. I would like to know if medicines are available in Sierra Leone to treat children, especially during diarrhea episodes, for example. So do families have the means to treat their children?
And I think we can end on a high note here for how things are.
Thank you very much for your question. Yes, medicines are available we're grateful for the free healthcare initiative that started in 2010, and also to the developing partners, UNICEF, UNFPA, and others who've been supporting the government in providing financial and medical support. So there are medicines. The only problem is sometimes there may be stock out. So it's something that I'm also going to look at. So sometimes it takes a while for the facilities to have restocking of the medicines, and that can delay, the provision of healthcare. But definitely, yes, medicines are available. And also, in terms of diarrhea, yeah, so the common treatment is given zinc and ORS. So there's the manufactured one, and there's also, people are also educated about using the local sugar salt solution in case the original, the manufactured one is not available. But then the other problem will be, contamination of the water sources. That's another thing to talk about. Thank you very much.
And with that, I think we have come to an end. We went 13 minutes over, but since we had a keynote that got canceled at the last minute, I think we're good. I would like to thank all of you for your excellent participation. I would like to thank our presenters for a great job and sticking to time, even though you didn't need to in the end. But it's an excellent piece of work, and I'm very happy to say hello to those that were online as well. So thank you very much, and we have a long, I guess, coffee lunch break for this, so we will be back for the afternoon sessions. Thank you very much.